today we're going to discuss about Parkinson plus syndrome. Okay, so what is this Parkinson plus syndrome? Parkinson plus syndromes are a group of disorders where the patient has Parkinsonian feature. Okay, but they're little atypical in nature. Okay, second, it progresses rapidly. Third, it does not respond well to levodopa. Okay, these are the key feature of Parkinson plus syndrome. One is that patient has atypical symptoms. Okay, normal Parkinsonism is usually asymmetrical. That means a right half of the body may be affected more than the left. Okay, whereas in Parkinson plus syndrome, usually they have symmetrical involvement that both half of the body are equally affected. Okay, symptoms of Parkinsonism, as we mentioned in the last lecture, it is bradykinesia, rigidity, tremor, and postural instability. The second key feature of Parkinson plus syndrome is that they are usually progressive. Okay, that means by 3 to 5 years, the patient may have severe disability. Third feature is they do not respond well to levodopa, which is in contrast to Parkinsonism, the idiopathic Parkinson disease. Okay, so one of the Parkinson plus syndrome is called multiple system atrophy. That means, as the name suggests, there are multiple systems within the brain which are getting atrophied. So it's also called alpha synucleinopathy because alpha synuclein is a protein which is accumulated in these patients. Okay, so few of the degenerative disorders are classified based on the type of the protein or which is accumulated. For example, we have something called tauopathies. Okay, tauopathy there where a protein tau is accumulated. The key example will be Alzheimer's disease. Then we have alpha synucleinopathy, which includes Parkinson disease and some of the Parkinson plus syndrome. Okay, in between we have A beta amyloid, which is the one of the extra Parkinson plus syndrome. Okay, so you might get tauopathies, alpha synucleinopathies. Okay, so do not get confused. These are just name of the proteins which are getting accumulated in specific diseases. Now, how multiple system atrophy is different from other or Parkinson disease? So, in addition to Parkinsonism, they have autonomic disturbance. So that means atonic bladder, postural hypotension. They may have cerebellar signs. They usually respond poorly to levodopa. So, if you have a patient who's got Parkinsonism features like bradykinesia, rigidity, tremor, along with the autonomic disturbance or cerebellar signs, do consider multiple system atrophy as one of the possibilities. The second Parkinson plus syndrome, which you should know, is called progressive supranuclear palsy. It is also known as Steele-Richardson or Alzheimer's syndrome. So, not worry about the name, just remember progressive supranuclear palsy. And very easy to remember the clinical feature here. As the name suggests, patient has an the gaze palsy. Okay, supranuclear with respect to is the to the extraocular movement. Okay, it's something like a human palsy to the human palsy of the eyes. Okay, so here the patient has impairment vertical gaze. So when we use vertical gaze, that means moving up and down. Okay, so we use up and down when specifically when we go downstairs. Okay, when we go downstairs. So the because vertical gaze is impaired, the patient has difficulty going downstairs. Okay, so patient may have recurrent falls. Patient may have difficulty in reading. Again, reading requires vertical gaze. In addition, patient may come with Parkinsonism, recurrent falls because of the vertical gaze impairment. There could be slurring of speech. They may have cognitive impairment. Management again, poor response to levodopa. So, poor response to levodopa is a common feature for all Parkinson plus syndrome. Progressive supranuclear palsy is basically problem in vertical gaze and patient has recurrent falls. Third Parkinson plus syndrome is called Lewy body dementia. It is one of the second most common cause of dementia in UK, following Alzheimer's disease, which is the most common type of dementia which you see in UK. Pathology here is the accumulation of Lewy bodies. Okay, Lewy bodies are present in the cytoplasm of a cell in areas of the brain such as substantia nigra, paralimbic area, neocortical areas. And how do these patients present? These patients present with progressive cognitive impairment, intermittent confusion, Parkinsonism, visual hallucination, autonomic deregulation. Okay, the two important features which distinguishes Lewy body dementia from from the Alzheimer's or Parkinsonism is the intermittent confusion and visual hallucination. Okay, so in the question scenario, do look for these specific terms. So, cholinesterase inhibitor, which are used as a treatment for Alzheimer's disease, may decrease hallucination and confusion. Neuroleptic, which are anti-dopaminergic drugs, should be avoided because it may precipitate irreversible Parkinsonism. The fourth Parkinson plus syndrome is known as cortico-basal degeneration. Cortico means cortex, basal means the brainstem, degeneration. Here again, it presents like a asymmetrical limb rigidity similar to Parkinsonism. In addition, they have apraxia. What is apraxia? Apraxia means inability to perform learned motor activity. Okay, I'll give an example. Patient may forget to button or unbutton their shirt. Okay, patient no shirt. Okay, what is the use of how to perform how to wear the shirt? Okay, patient has an idea, but he is not able to do it. Okay, there is no motor weakness. Okay, so this is called as apraxia, inability to perform learned motor activity. These are usually signs of parietal lobe involvement. They have alien limb phenomena. Alien limb phenomena means the patient perceives that his right or left upper limb or lower limb is alien to him. That means doesn't follow his command. Okay, that is called alien limb phenomena. They have dysphagia, which is inability for speech. Apraxia of speech, again, a difficulty in telling a complete sentence. So these are the key feature. Alien limb phenomena is a key feature to distinguish or to diagnose corticobasal degeneration. These are MRI images, which basically shows diffuse cortical atrophy. You can see diffuse cortical atrophy here, nothing else. Moving on to the topic, dementia. Dementia means loss of memory. The most common cause in the UK is Alzheimer's disease, followed by vascular dementia. Third is the Lewy body dementia. Now, how to say that patient is dementic? You have to do what's called modified mini mental status examination, that is MMSE, where you're going to assess the patient's cognitive function by asking few questions, trying to get some calculation, and trying to get their response from the few of the scenarios or few of the statements. Okay, so the maximum score what you can achieve is 30. So if somebody scores less than 24, patient can be called as dementia. How do you evaluate such patient? There are some treatable causes of dementia as well. Okay, for example, somebody has vitamin deficiency, endocrine disorders. Okay, so we need to rule out those causes. So for that, we need to do a full blood count, urea and electrolyte, liver function test, calcium, glucose, thyroid function test, vitamin B12 test, and folate levels. And there are a few rare causes of dementia which can be treated surgically. For example, subdural hematoma can present like an dementia. Normal pressure hydrocephalus, another disease which can present with dementia. Okay, so cause of dementia could be degenerative like Alzheimer's disease, could be vascular like multiple stroke. Some rare causes like metabolic, toxin, vitamin deficiency, mass lesion, infective and endocrine causes. Do remember these rarer causes are treatable causes, and we have to do an MRI or a CT to rule out normal pressure hydrocephalus and chronic subdural hematoma. Moving on, Alzheimer's disease. This is one of the most common cause of dementia in the UK. Most of the cases are sporadic. Only 5% have family history. Is because of mutation in the protein called activated protein P. So, which is present in chromosome 21. Chromosome 21 is also a chromosome which is involved in Down syndrome. So, patients with Down syndrome have increased risk of Alzheimer's disease. Other gene which could be contributory could be present in 1 and 2. So what are the risk factor for Alzheimer's disease? Family history of mutation or polymorphism in apolipoprotein E4, which is one of the lipoproteins which is available in the blood. Traumatic brain injury, Down syndrome, uncontrolled hypertension, obesity, insulin resistance. Pathologically, if you might macroscopically, that means gross, when you inspect the brain, you might have atrophy, especially at the cortex and hippocampus. Hippocampus is also called memory center. That you can correlate that when you have atrophy of the hippocampus, you are more likely to develop memory disturbances. Microscopically, you might find what's called as intraneuronal neurofibrillary tangles. Okay, so these are the protein material which are accumulated inside the cell, and outside the cell, that is neurons, you might find what's called plaques. Biochemically, these plaques are made up of A beta amyloid. Neurofibrillary tangles, which are basically present within the neuron, okay, cell, which is basically made up of a tau protein. That's Alzheimer's disease, also called as tauopathies. So patient here will present with progressive dementia, initially language disorder. That when patient has difficulty in remembering names, remembering objects, okay. Then subsequently visuospatial memory loss. Visuospatial memory loss means, remember, they do not have the geographic memory. That means suppose you close your eyes, you will be able to know where is the kitchen in your house, where is the where is the dining hall in the house, and where is the nearest bus stand. You can imagine yourself because you have seen them. Okay, whereas these patients with Alzheimer's disease, they have visual spatial memory loss. Okay, so that means they do not remember the exact structure of their own house where they are living, or the neighboring places. Okay, that's why they may feel, you may find them wandering in the street. Okay, management is usually we give acetylcholine esterase inhibitor, which will temporarily increase the acetylcholine level within the synapse. The common drugs which are used are donepezil, galantamine, and rivastigmine. All are used for mild to moderate Alzheimer's disease. The problem with these drugs, because they're anti-cholinesterase inhibitor and they're going to increase the parasympathetic response, you may have bradycardia or AV nodal block, sometimes insomnia. For moderate to severe Alzheimer's disease, we can use memantine. It's another drug, and definitely we should avoid haloperidol in these patients because they may cause Parkinsonism. So this is a structure of the neuron, normal neuron. This is a structure of an Alzheimer's disease. You can see neurofibrillary tangles which are made up of tau protein. Outside you have amyloid plaques which are called neuronal plaques.